Hello everyone. Today we will be talking about an important aspect of periodontology, that is the periodontal pocket. A 2 to 3 millimeter depth gingival sulcus is normally present between the soft tissue on one side and tooth on the adjacent side. This is a normal finding in an individual, in each and every individual. This can even be as less as 0.5 millimeter in a healthy oral cavity. However, due to the presence of plaque and calculus, there can be an increase in the depth of this particular sulcus. The base of the sulcus is attached to the tooth surface by means of junctional epithelial cells. These junctional epithelial cells, because of plaque and calculus, there is a tendency for these cells to migrate apically. When these cells migrate apically, it leads to an increase in the depth of the gingival sulcus, and this increase is known as a periodontal pocket. So, periodontal pocket is defined as a pathologically deepened gingival sulcus. It is one of the most important clinical features of periodontitis. Presence of a periodontal pocket signifies an active periodontitis condition and should be addressed as soon as possible. If left to progress, it leads to destruction of the underlying supporting structures of the periodontium, loosening and gradually exfoliation of the teeth. Now, there can be, when you come to its classification, there can be an increase in the depth of the sulcus due to, as seen in the figure, due to a downward movement of the junctional epithelial cells or an upward movement of the gingival margin. When it occurs due to an upward movement of a coronal movement of the gingival margin, it is known as a pseudo pocket. When the increase in depth occurs due to a downward or an apical migration of the junctional epithelial cells, this is known as a true or a periodontal pocket. However, there can be conditions many a times when a pseudo pocket and a true pocket can coexist. It is important to know the difference between a true and a pseudo pocket because the treatment aspect for both of them will vary. A periodontal pocket, also known as a true or an absolute pocket, can further be divided into a suprabony pocket or an intra or an infrabony pocket. A suprabony pocket is when the base of the pocket, it lies coronal to the crest of the alveolar bone, and an intrabony or a subcrestal periodontal pocket is when the base of the pocket lies below or apical to the crest of the alveolar bone, as can be appreciated in this figure. The base of the pocket is here and the crest of the alveolar bone is above the base of the pocket, and the red aspect that we see is it is depicting the inflammatory aspect of the in the figure. That is the plaque and calculus. There are few differences between supra and an infrabony pocket which are mentioned here. Suprabony pocket is related to horizontal bone loss and infrabony pocket is related with vertical bone loss. Infrabony pocket can also be further classified into a 1-wall pocket, 2-wall pocket and a 3-wall pocket. Now, depending upon the activity present within the periodontal pocket, it can be disease activity that we are talking about. It can be divided into an active and an inactive or a passive pocket or a quiescent pocket. Active pocket is one where the pocket is present. There is a depth in the there is 5 millimeter and beyond depth in the sulcus is present, and of course it is present along with all the active inflammatory components of inflammation. There will be bleeding, there will be purulent discharge, there will be a change in color. However, when the body immunity is strong, the body has overcome the disease activity, it can also remain in an inactive or in a quiescent stage. The depth will remain the same, but the clinical manifestations of active lesion will not be present. Another classification is depending upon the nature of the soft tissue wall, it can be an edematous and a fibrotic pocket. Edematous, as the name suggests, it will be soft and edematous. Fibrotic there is a shift from the edematous component to a fibrotic, because we know that the disease is in an active and a quiescent stage. So in a quiescent stage, there will be deposition of the fibers of the reparative activity that is taking place, and this reparative activity will lead to the pocket being converted into a fibrotic component. Another classification is depending upon the number of tooth surfaces involved. When it is present only in a single tooth surface, on one tooth surface, it is known as a simple pocket. When two surfaces are involved, it is known as a compound, and when two or more, for example 3 surfaces are involved, it is known as a complex pocket. This is most commonly seen in your furcation areas, where the pocket begins in one aspect of the tooth, it spirals at one end and then it goes and meets in the furcation area. So 3 surfaces are involved, making it a slightly more complicated aspect from the treatment point of view. What other clinical features that is seen in a periodontal pocket? The gingival wall remains, it appears as a varying degrees of bluish red discoloration. It is flaccid. Sometimes it will be smooth and shiny. Sometimes the fibrotic component would have taken over, and there can be pitting on pressure that can be seen less frequently. We can also have a component of it appearing to be normal, as in pink and firm. As mentioned before, this is in a fibrotic condition, that means it is in a quiescent stage, but the pocket is still persistent. Bleeding on probing will be present, and sometimes there will be purulent discharge also present. Other features that are present, there will be a deep radiating pain from deep within the jaws, an urge to dig material from deep within the jaws. Patient most often complain of food getting stuck between the teeth, a gnawing feeling, sensitivity to go hot and cold can occur. Patients often complain of a foul taste in the oral cavity, and also finally it leads to pain in the tooth. This periodontal pocket is measured by means of a Williams graduated periodontal probe, which has markings from 1 to 10, where 4 and 6 are missing. Apart from this Williams graduated periodontal probe, there are other probes also available which can help in measurement of periodontal pocket. One must only stick to these specialized probes and not measure or mark the pocket by any other explorer or any other probes. These are specific probes used for this purpose. Coming to the conclusion, the inflammatory, proliferative and degenerative changes in both supra and infrabony pockets lead to destruction of the supporting periodontal tissues. In the next topic, we will be discussing about the treatment aspect. Thank you.